All right, let's get started here tonight. Thank you everyone for joining us again. This is our third talk in our Women's Fertile Health Speaker Series. If you haven't joined us before, my name is Tavia and I work at Evolve Egg Freezing. And today we have decided to talk a little bit about the mental health side of things. So we're very lucky to be joined by Dr. Ariel Delphin from BRIA Mental Health, and she will be leading us through the talk tonight. So Dr. Delphin is a women's mental health psychiatrist with over 20 years experience and is one of the co-founders at BRIA, which is a virtual care service for women who are struggling with their mental health issues across different reproductive life stages. So a great fit here in our speaker series. Prior to starting BRIA in 2022, Dr. Delphin worked at Mount Sinai Hospital in Toronto, where she was the head of Perinatal Mental Health program for 12 years. And in 2014, she created the Perinatal Mental Health Telemedicine program, which was an innovative and first of its kind program that provided specialized mental health care to women around the province of Ontario using mobile technologies. After completing her undergrad degree at Princeton University, she went to McMaster University in medical school and then completed her specialty training in psychiatry at Tamarte Faculty of Medicine right here in Toronto at the University of Toronto. She's an assistant professor in the Department of Psychiatry at the Tamarte Faculty of Medicine and has published both medical journals and has been published in popular media. She lectures for both medical and public audiences and has been a medical contributor on various television programs and other media outlets. She also has a book that in 2009 she wrote called When Baby Brings the Blues, Solutions for Postpartum Depression. So without further ado, I will pass it over to you, Dr. Delphin. And as a reminder, everyone, please put your Q&A if you have questions along the way in the Q&A box, and we will get to them at the end. Thank you.
Thank you so much, Tavia, and thank you for coming tonight. I know it's a beautiful night out there, and but I'm thrilled to be here talking to you. And I'm going to really talk about psychiatric issues while trying to conceive, as well as during pregnancy and the postpartum period, because I think it's really important for people to know about how to treat at all these different stages, and hopefully if you see people who are trying to conceive, that they continue through pregnancy and postpartum, and it's really important to have a sense of what the treatments are and how to recognize issues. So what I'm going to cover tonight are the following objectives. I want to talk about the common reproductive mental health issues, to talk about how to recognize risk factors and what the risk factors are for perinatal mental illness, and to really talk about treatment principles, as well as understand some of the myths and the realities of psychotropic drug use across these stages that I mentioned. So I will jump right in and just present my disclaimer to say that when I do get to the point of talking about medications, that a lot of the medications are off-label uses of antidepressants and other medications during pregnancy and lactation, but they are backed up by data and they are backed up by evidence, but they are off-label uses. So let's first start, because I suspect those of you coming tonight are interested in either egg freezing or in supporting people who are going through the fertility journey. And I just want to set the stage by talking about some of the concerns that people have related to their mental health. And if you're already involved in treating this population, you will know that there are very high rates of depression, as well as high rates of anxiety, and very high rates of overall distress because of the huge time commitment, financial commitment, a lot of the uncertainty, and a lot of the trials and tribulations with medical procedures that people go through. when they're trying to conceive or going through the fertility journey, this can be a very, very significant time in a woman's mental health as well as her reproductive journey. And we know that the literature says, as I mentioned before, about rates can be up to about 50% of people going through these processes can struggle with mental health diagnoses. And I will talk about what the symptoms look like. And of course, with a lot of stress that might come out in different ways in terms of behaviors, in terms of how they interact with healthcare providers, how they interact with partners, and it can lead to a lot of challenges for people overall. So, um, of course, because this is often the beginning of someone's reproductive health journey, it is really important that people get help. And it's important that we understand how to diagnose and treat at this stage, not only for the person to feel better, for them to feel healthier and feel like they can function in their roles at home, in their relationships, and function at work, but also for healthcare providers and for fertility clinics. It's really important to help with the resilience and them to be able to sustain themselves throughout the journey and to be able to follow along with some of the things that we ask of them as healthcare providers or that you may be asking of them as clinicians or in particular at fertility clinics. So getting help is very essential. And I'm going to talk about some of the principles of help and treatment and diagnosis as we go. Moving from the trying to conceive space until pregnancy, I think it's also really important to understand the rates of perinatal depression and anxiety. It used to be thought that pregnancy was really a golden age for women, that they didn't suffer, that they were so thrilled always, and they just didn't have any mental illness. But in fact, we know that the rates of depression and anxiety in the perinatal population are really the same as they are in the general adult population. So you'll see it's a little bit less than those who are going through the fertility journey. And about all women have rates of depression and anxiety between 10 and 25%. And in fact, that is the same during the pregnancy. We also know that at this stage, it's often really hard to diagnose. It's hard for people to come forward. And perinatal mental illnesses in general are under-recognized. They're often underdiagnosed by healthcare providers who feel confused about what symptoms are related to the pregnancy versus what are related to mental health problems. And that underdiagnosis, unfortunately, leads to undertreatment. So we know, and I'm going to talk to you and hopefully give you the confidence to diagnose and treat, that it's really important to address and diagnose and to treat. And there are a lot of safe and effective treatments that are out there. So as you can see here, the slide is busy and has a lot of words, but I just want to be sure we're all on the same page in terms of understanding the actual clinical symptoms of depression and of anxiety. And if we think about what the symptoms are in the Diagnostic and Statistical Manual, which is kind of the Bible of all psychological and psychiatric diagnoses, both depression and anxiety have a bucket of psychological symptoms as well as physical symptoms. So you can see here in the navy blue, the symptoms of depression are feeling down or having a depressed mood, anhedonia, which is lack of joy, feelings of guilt, hopelessness, worthlessness. And then in the more serious situations, there can be suicidal ideation. People thinking they can't go on, they want to end their lives, and they can't live with this burden of pain. And in the bucket of anxiety, there can be some of those as well. And I put these on one side because often in perinatal depression and anxiety, there can be a lot of crossover. So if someone has an anxiety problem, it's usually characterized by excessive worries, obsessionalities, thinking about things and worrying about things, ruminating over and over again. as well as it can come out in terms of intense anger or feelings of irritability. And so these are some of the flavors that we often see with anxiety and depression in the psychological symptoms. We also know that physical symptoms are very prominent in most mental health problems, and these very often include sleep issues, appetite, and weight changes often, sometimes too much of an appetite and weight gain, or too can also be too little and weight loss. Depression and anxiety can also impact someone's mental functions, such as concentration or memory, and it can also impact their energy levels. So people would often describe with depression feeling really tired, feeling slowed down, feeling lethargic. And that's what psychomotor disturbances can be in part. And the other part is more with anxiety, where people feel kind of revved up and uh, on edge and feel intense physical symptoms like physical pain, a knot in their stomach, tightness in their shoulders, tightness in their jaw, and really overall body aches and pains and a feeling of being revved up. So these are the very common types of symptoms and signs that we see in pregnancy, as well as those trying to conceive, and also in the postpartum population. And as I mentioned before, it's often hard for patients themselves or for healthcare providers. Is this just pregnancy or are these actual mental health issues? So, usually, when we're trying to make a diagnosis during pregnancy, we rely less on the physical symptoms because there's so much crossover. Sleep, appetite, energy levels, etc., can be a little bit distorted during pregnancy as well. But the common sort of gestalt of mental health, depression and anxiety, and the common symptoms we see are an intense sense of worry, not being able to turn off that worry switch, just worrying about every little decision. Should I eat this? Should I dye my hair? Should I wear this kind of skin cream? Or, a lot of worry about things to excess. And also things like if you ever start to hear of patients or clients talking about not being interested in their pregnancy, not being interested in the baby that's coming in a really profound way, that is concerning in many situations. And then there's often guilt. I always say to my patients that guilt is one of those emotions that it sort of accompanies people and women along the reproductive health journey, along the parenting journey. But often women describe feeling like, what's wrong with me? I must be a bad parent if I'm not feeling 100% elated about being pregnant, or if I'm worrying so much. I must be a bad mother. What's wrong with me? And there's a lot of guilt that's involved. And also, if we see people who just describe themselves as being very different from their normal self and withdrawing from situations, withdrawing from things that they normally liked and could engage in, that's another concerning symptom. I also often say to my patients that I'm a bit of a broken record when it comes to talking about sleep. And when someone describes a profound inability to sleep, especially, and we always want to ask them, are you not able to sleep because of your stage of pregnancy? Or is it something else? And people are good at describing, I'm up to pee, so that's really disruptive, or I'm really uncomfortable. But you want to figure out if they can't sleep because their mind is racing or they're so worried, then we're more into the mental health range of things. And then, of course, as I mentioned before, the more severe situations when people have suicidal thinking, or if they have fantasies about wanting to escape from their life, that's really concerning. And then when there's doubt, it's always really important, especially during pregnancy when there can be medical issues at play. It's important to rule out and to treat any underlying medical problems. And things such as anemia or thyroid issues may present either as depression or anxiety. So we want to always stay on top of that and rule out things before we can say, okay, this is pregnancy, or no, this is in fact a mental health issue that you're struggling with and we need to address. So as I was saying, I think it's important in order for us to when we're talking to patients who are pregnant, the best and most sensitive way to elicit what's happening and to understand a person's mental health risk is to ask about their personal psychiatric history. Now, I will tell you, people often ask, should we screen in our office? Should we not? Screening is a bit controversial, and the reason it's controversial is it's a great thing to do if you have something you can do with the answers. So if you're just giving people screening questionnaires and there's nowhere to send them if they have higher scores, or if there's nothing you can do with the information, it's not the best idea to just open it up. If you are able to, if you have healthcare providers, mental health care providers that can provide follow-up, that provide care, that can keep following, then screening is a helpful thing to implement. And if you don't do formal screening in your office, it's really important to ask all pregnant patients about their personal psychiatric history. This is the most sensitive way to elicit risk. And so we know that relapse during pregnancy is very common among people who have a psychiatric history. This was sort of a seminal paper in the area of perinatal mental health that came out in JAMA, the Journal of the American Medical Association, in 2006. And it really illustrated how high risk of relapse people are who've had a previous history. So people who stopped or discontinued their medications had almost a 70% relapse rate. And even among those who did continue their medications, about 26% relapsed. And so we see very high rates of relapse if someone has a previous diagnosis and treatment plan. And this paper really showed how the first trimester is the highest risk time, having had more than 4 episodes of a mental health problem in the past, as well as more than 5 years of mental health illness in total, make someone in a very high risk category. So again, this is the data that backs up asking people about their mental health history, and it can get you thinking, okay, how closely do I need to monitor this person? What do I need to do to pay close attention here to see what this person may need and how closely they need to be followed? So I'm going to obviously, I'm going to talk about treatment, et cetera, after, but I just want to do a bit of an overview and continue my overview now into the postpartum mood disorder category. So when we talk about postpartum mood disorders, the main ones are these that we talk about. So baby blues, very, very common. It's actually not considered a psychiatric diagnosis or psychiatric disorder. And it occurs in very high rates. Between 50 and 80% of new moms have baby blues. It starts in the first, it starts in about the first few days after coming home from delivery. And it sort of peaks around day 5 when someone's milk comes in. And it usually lasts about 2 weeks. And it's characterized by tearfulness, feeling sad, feeling overwhelmed, but it should go away with some reassurance, some rest, some extra support. And it's important to pay attention to it if you're a healthcare provider who sees people at this stage, because if it doesn't go away, or if it's particularly severe, you may be noticing someone getting into the category of actual postpartum depression, which happens to about 15 to 20% of new moms in the early postpartum period. And I'm going to talk some more about that. And then on the more extreme, more severe, but much less common, we have postpartum psychosis, and that occurs to about 0.1% of new moms. That's a psychiatric emergency. If you see someone who's struggling with that, usually they need to go to the emergency room right away. They often need to be admitted to hospital, and they're often treated with a combination of antipsychotic medications, sometimes mood stabilizer medications. And the reason for mood stabilizers is that often it is people who have a previous diagnosis of a bipolar affective disorder, or who've actually had a previous postpartum psychosis, or both, often both, who develop postpartum psychosis. So in terms of postpartum depression, this can happen, and in the most recent psychiatric Bible, the DSM, This can happen to people up to a year postpartum. Usually, the highest risk times for onset are within the first 3 months postpartum. And again, it's often characterized by the symptoms that I mentioned before: depression, sadness, withdrawal, sometimes just an inability to bond with the baby. And there can often be also a lot of comorbid anxiety, even in postpartum depression. So the diagnosis specifically matters less than actually identifying that there are a lot of symptoms of depression, a lot of symptoms of anxiety. And again, the worries just get ratcheted up. People worrying about absolutely everything, decisions they make, the baby schedule, sleep, feeding, you name it. A woman who's struggling with postpartum depression and with postpartum anxiety will worry about it and worry about it over and over again. So I'm going to move on and talk about what the risk factors are, because I think if you walk away with nothing from this talk tonight, it is really to think about who is going to be at risk. And that's whether you're seeing people who are trying to conceive, or if you're seeing people who are pregnant or postpartum. The risk factors are very similar. So the major risk factors that we look at are someone who has a history of significant premenstrual problems, um, and or depression, anxiety if they've actually been pregnant before. And these are people who we know who are most at risk for developing mental health problems as their hormones, their estrogen and progesterone, fluctuate. So often you can elicit a history of someone who's had severe premenstrual mood or anxiety problems. They probably are vulnerable if they're going through fertility on the medications that they're getting to support and enhance sometimes egg freezing, sometimes fertility, as well as during pregnancy and postpartum. And that is because of that vulnerability to hormonal fluctuations in terms of their mood and anxiety. And and so we see this time and time again. So it's really helpful to elicit a history of all of these things. And then, of course, if someone's had a history of postpartum depression or anxiety, as well as psychosis, there are high rates of relapse and recurrence. And then in general, if someone's had a mood and anxiety disorder external to reproductive health issues, you want to be thinking about that. And then finally, a family psychiatric history. It's really important to know about. Often people don't know if their mother has had postpartum depression. Maybe wasn't talked about. Maybe it was, but often it isn't. But it's helpful to know about that as a risk. Um, and then other significant sort of tier one risk factors are someone who has very limited social support at the time of pregnancy and the postpartum period, or who may be experiencing very stressful life events as well. And then these are some of the other risk factors we see. Very commonly, we'll see people who have a perfectionistic personality. So these are people who are used to functioning, sort of the type A type, used to being organized and scheduled and on the ball. And that's how they function and that's how they feel good. And of course, when you're pregnant and your body's changing, or you're postpartum and you're bringing a baby home, nothing really goes according to plan at first. You can't be on a schedule. It's really overwhelming. And for people with this personality structure, it can be a very stressful, highly anxious time. And then other factors are people who have significant relationship issues, including who are experiencing an abusive scenario or domestic violence, um, as well as those who've gone through significant pregnancy issues, such as having a traumatic pregnancy or a traumatic labor and delivery. They've had medical complications and even fertility challenges, or unwanted pregnancies. These are a lot of the issues described in the literature that put people at risk for perinatal mental illness. And then there are infant types of difficulties. So those who have nursing challenges, breastfeeding challenges, um, you know, day in and day out, we talk to women who are challenged by nursing and the pressures, and can lead to a lot of depression and anxiety in the early days postpartum, as well as babies who are very difficult to soothe and colicky. And then finally, people who are at the younger age of things are at a higher risk, more in the teenage pregnancy, and that's an independent risk factor from the stressful life events or other things as well. So moving along, once we have identified that someone is at risk or that someone may be having symptoms and struggling, we always want to think about what the risks of treatment are, of course, but we also want to think about the risks of not treating. There are a lot of risks associated and documented really extensively in the literature with not treating mental illness during pregnancy or in the postpartum period. Risks on the mom, risks on the family, and risks on the baby as they develop in terms of behavioral issues, later mental health issues in life, or during pregnancy, people who maybe turn to substance use or overuse to self-manage and self-medicate. So really, there's no such thing as non-exposure, and and so what we often want to do with our patients is walk them through the pros and the cons of each side and have them think about what are the risks of not being treated versus what are the potential risks of treatment, and in particular, medication treatments. So whenever we're thinking about treatments, we as psychiatrists use something called the biopsychosocial model. And we look at all the different factors that may be at play in someone. So in the biological realm, that's past psychiatric history, other medical issues, other medications that someone may be on. And then the psychological, we want to help boost a person's coping skills, their relationships, and how they view themselves and the confidence that they may or may not be bringing to the table. And then finally, the social factors is, do they have support? Those are some of the basic things. And then some of the larger picture things are, are people underhoused? Do people have enough food? Do people have, and then of course we get to the bigger picture things such as living during a pandemic or living in a violent place or a war-torn place. Those are not often issues that we can directly address as treatment providers, but they're helpful to be aware of when we're thinking about how to treat and what some of the factors that may be impacting someone. So whenever we want to treat, the earlier the better, and that's why I mentioned at the beginning. During the fertility process, very important to identify and to treat someone who may be struggling, because the earlier we can intervene and identify, the better things are. And of course, that goes with the same. If there are confounding medical issues, we want to look at medications. We want to straighten up medications. We want to make sure that people don't have untreated medical issues that could be exacerbating their mental health. And of course, sleep is always very key and one of the main pillars of any kind of treatment at any stage. So we often talk to our patients about how to get better sleep. We have sleep consultants that we work with at BRIA that we often refer patients to, or we work with them on developing a sleep plan, because sleep is one of the most essential things that people can do for their mental health. I'm not going to talk a lot today about some of the social interventions, but it's often really important to talk to people about increasing their support system, engaging family, engaging friends in helping them in ways that can make life a lot easier and offer them more supports of different kinds. And then, of course, other larger community or social supports that may be available to people, such as social worker or public health nurses. These are also very helpful people as part of someone's team that can jump in and be a part of things. Some of the main, most evidence-based treatments and sort of first-line treatments for mild or mild to moderate mental illness throughout the perinatal period are psychotherapies, so individual therapies. There's evidence, very good data for things such as cognitive behavioral therapy, but also other therapies have been shown to be very good. Supportive, expressive therapies and different types of therapies are also very helpful. Group therapy may be an option for some people. And of course, couples therapy is essential if there's relationship strife or relationship difficulty. And just psychoeducation. So going to a provider that can help people understand their symptoms, hearing what's going on, learning about what is normal and when they need to get help, and understanding the course of illness. That's also very powerful intervention for people. And then finally, we have medications. So as I said before, first line evidence-based treatments are psychotherapies for people who have mild to moderate, and those with more moderate to severe symptoms usually require medication treatments. So I put this picture here because medications during, especially for people going through fertility process, during pregnancy and postpartum, if someone is nursing, can be a moving target. And there are always stories in the news about a medication being unsafe and patients calling and very worried, or patients just stopping medication suddenly and going into withdrawal and having relapse. So it's a real moving target, and really important for providers to feel comfortable asking about medications, providing safe treatments, and knowing what the actual evidence and data shows. So when we're thinking about prescribing medication, providers often want to know about risks of prenatal exposure, and patients often want to know, is this safe to take during pregnancy? So when we look at the literature, and a good way I find to think about it is to really break it down into these three categories. We look at whether a medication has evidence of teratogenicity or organ malformation, which happens during the first trimester. We want to look at neonatal adverse effects, which happen after delivery and the third trimester. And then we want to look at the data about long-term sequelae of medication on a baby and on a child and on a person as they develop later in life. So the good news is, and I'm going to walk through the list of some of the commonly used medication, is that most medications, many medications, are fine to take during pregnancy. So there's really reassuring data about a lot of the medications that we use to prescribe commonly for common depression, common anxiety. So that's really the good news of all of this, is that there seems to be, there's almost more data about psychotropic drug use during pregnancy and while nursing than any class of drugs, because of the stigma around taking psychiatric medications and some of the issues related to that. So we do have a lot of data to back up what we say and to back up the safety. I often suggest to people as healthcare providers, it's important that they know how to explain to people that that neonatal adaptation syndrome, which happens right at birth, is one of the more common things that we see, especially in the common use drugs such as the SSRIs or the SNRIs, either the selective serotonin reuptake inhibitor class of antidepressants or the serotonin norepinephrine reuptake inhibitors. Those are commonly used medications for depression and anxiety. So we want to let people know that the symptoms are transient, that they'll resolve in a few days' time, and that there are really no long-term effects on the baby. Some sites and do offer more intensive monitoring. A lot of data shows that that's not actually necessary, but we often tell patients, monitor your baby for the first 48 hours and longer if the symptoms seem severe. And a lot of the symptoms seem to be difficulty breathing. Sometimes a baby might look like it has a higher rest rate. Maybe it's a little bit more jittery than one would expect. But again, these symptoms are transient. They don't have any long-term effects. And these medications have been around for about 20 or 30 years. So we have a lot of data to support that. And we never suggest that someone stop the medication that they're on and that they've been prescribed in the third trimester in order to avoid this. Because the babies have already been exposed to it during pregnancy. And it's also very dangerous to stop a medication that a woman needs at a time when she's entering the postpartum period and is going to be at high risk of having depression and anxiety. So it's basically a watch and wait type of scenario that we advise. As I said before, important to think about medication for people who have moderate to severe symptoms. If someone's obviously on an antipsychotic or on a mood stabilizer, they must continue that, because those are usually treatments that can prevent postpartum psychosis. If someone has thinking about pregnancy and they come to you and they're wondering, or they are already pregnant and they've had trials off of medication and that hasn't gone well, they should also be taking medication. And that's the same for people going through the fertility process, as well as for people who've had a history of relapse during pregnancy. People who fall into these types of categories usually do need to have pharmacotherapy to support their mental health. So this is a very busy slide. I will give you a second to read it, and then I'm happy to answer any questions after, at the end of my talk about it. I am getting towards the end. I'll give you a second to read it. So as you can see here, the most commonly prescribed antidepressants and anti-anxiety medications are the SSRIs and SNRIs. They're fine. They're fine to take. Usually what we do is just warn people about the neonatal withdrawal effects that I just spoke to you about. A lot of the times, sometimes people need to be on typical older antipsychotics. Again, those are considered to be okay. Even more commonly now, people are on atypical of some of the newer antipsychotic medications, olanzapine or quetiapine or risperidone. Again, these are considered to be compatible with pregnancy. Because of some of the metabolic effects, we often suggest monitoring maternal blood sugars and weight throughout pregnancy. A lot of the medications we use to support some of the mainstay treatments, like benzodiazepines for sleep or for panic attacks, those are also okay to take during pregnancy. It used to be thought of that they weren't because they would have an increased risk of cleft lip and cleft palate, but that data has been revised and does not, seem to be overly concerning. The goal with this is we want to get people on the lowest possible dose towards the end of pregnancy to prevent withdrawal. And then finally, zopiclone, which is also Imavane. There's limited data, but the data that we do have does not appear to be harmful. So these are probably the medications that we see people on the most. And it's reassuring that they are okay to continue and to continue as is during pregnancy. During nursing, it's interesting. Sometimes people will say, oh, I want to stop all my medication after pregnancy because I want to breastfeed. And the reality is that a lot more of the medication, the baby's exposed to a lot more of the medication during pregnancy versus nursing. So we want to educate people that the exposure via nursing is really a lot less than it is during the pregnancy period. We do know that all medications are excreted into the breast milk, and something is considered to be safe. The standards of safety are such that if it comes into the breast milk at less than 10% of the parental dose, it's considered to be compatible with nursing. And so we really want to let people know that nursing doesn't have to be an obstacle to taking medications or vice versa. And people, seems to be a lot of information out there about nursing and, whether or not someone can take medication at that time. And basically, we just continue what worked during pregnancy or what someone was on prior to pregnancy. The only specific thing is lithium. And of course, I didn't talk about lithium during my talk because I didn't spend a lot of time talking about bipolar disorder, which lithium treats. But lithium is the one medication that if you see someone who's on lithium, it is okay to take during pregnancy. It's less advisable during nursing. But in a case like that, someone should be followed by a psychiatrist to properly manage their illness as well as to manage their medication. And really, there's no specific monitoring that's required for healthy babies who are exposed to medications via nursing. So again, you'll see here quite a high level list that the antidepressants are okay, the antipsychotics are largely okay, especially the atypical antipsychotics, benzodiazepines. We just suggest people monitor their babies for sedation, and we really avoid the longer acting ones such as diazepam. And again, zopiclone, if sleep is an issue, is something that is okay to take. So my take-home messages today are that pregnancy is not protective against mental illness. Really important to ask all patients about medication, about their psychiatric histories, because we really know people need to be monitored, identified. There are a lot of safe treatments out there, and we want to weigh the risks and the benefits of medication treatments and offer people availability of all other treatments as well. And not treating is not a good idea. And it's important for people to find the right type of care, work with a team of healthcare providers to really help patients and people and women and their families get the best possible help that they can and that they need at these stages. So here's a few resources that I really like and that we turn to a lot for general information. Mother to Baby is an excellent medication safety information geared towards providers, as well as there's printouts and information written in really very patient-friendly language. And all the rest of these I like as well. And this is a shameless plug for a book that I wrote a long time ago about postpartum depression. It's written for healthcare providers as well as for patients. And really, I think that what we're doing at BRIA is we've set up a service that's very comprehensive for women across reproductive life stages, as well as for their partners. We have everything from individual therapies to couples therapies to therapies for people's partners, as well as ND psychiatric care as needed. We have sleep consultants and lactation consultants and all types of services that a person would need as they're dealing with mental health issues across reproductive life stages. So our website is here. You can see it at betterbria.com, or you can reach out to our care coordinator at care@betterbria.com if you have any questions or you want any more information for yourself or for your patients. And it is all by self-referral. If we do need to access a referral for a patient, we do so by actually reaching out to the person's primary care provider or their healthcare professional. So you can send patients there, you can check it out. If you're interested yourself as a healthcare provider, you can call our wonderful care coordinators and set up a meet and greet to learn more. And I will pause there and happy to take any questions.
Thank you. Thank you for that. I actually have a few questions that came through. There are some people, for whatever reason, when they logged in, they're showing as a viewer only. And so I've had 2 questions emailed to me, so I will pose them to you now. What do we do with patients on medications before they get pregnant if we know they want to start trying? So I'm assuming this is that was the question. I'm assuming it is obviously a pre-existing condition for depression or anxiety or something of the similar, and they have a patient who's looking to maybe start a family.
So if the person is on one of the medications that I listed, and usually people are on, I'm going to assume they're on either an SSRI like the Zoloft or Prozac or Celexa or escitalopram. If someone is on one of those medications and they've been, assessed and diagnosed and are successfully treated and are stable on these medications, I would suggest you do nothing. You just tell them these medications are fine to take during pregnancy. They're fine for nursing and they can continue as is. If they fall into a high risk category, such as very long-standing chronic, hard to treat depression and anxiety, they should absolutely stay on it. If they've maybe been diagnosed, let's say 10 or 15 years ago, they had a very brief episode that was triggered by, a relationship breakup or some type of life stage stressor that is no longer a factor at all, and they've never tried coming off it, but they're really determined to stop their medication, they can slowly be tapered off it. They don't have a strong, complicated psychiatric history, and then they can start trying then. So it would really depend on how complex is their psychiatric history, how long have they been struggling, have they tried coming off and had relapses, Do they have active current stressors? And what is the patient preference, of course? So all of those things together, that I would want to understand about the patient. But so many patients we see say, you know what, I've had my ups and downs. I finally found a medication that works. I want to stay on it. If they're on one of those medications, fine. The only medications we do not prescribed to people who are pregnant or women of reproductive age, frankly, is probably valproic acid, and those usually used for people who have a diagnosis of bipolar disorder. Valproic acid and carbamazepine as well, which is less commonly used but can be used for bipolar disorder, are the only really major psychiatric medications that are not considered to be safe during pregnancy because of the unacceptably high rates of neural tube defects and some other issues in the baby and development. But other than that, it is fine to just continue as is, given all the other factors if they've been identified and thought through before.
Okay, thank you. And the other one that was just sent in, is there something you specifically recommend when someone has had postpartum depression before and is pregnant with baby number 2? Is there something that can be done ahead of time?
So I would say, first of all, it would depend on how they were treated in postpartum depression, number one, and what they were treated with. If that worked and that treatment plan went well, I would replicate it. So whether that's medication or starting therapy, I would just do the same thing again. If they've come off the medication in the interim, I would resume it. And then the question is when to resume it. So we see people sometimes who said, you know what, I've had such a hard time with postpartum depression with my first baby. I'm really nervous about having postpartum depression again. It was really hard to treat and it was really difficult. If I'm seeing them for preconception counseling, I would say just stay on it. Even if you're like a year postpartum or you're feeling better or it's in remission, if you're still in your reproductive years and you think you're going to either try to get pregnant soon or you're pregnant or I would just keep going. That's the safest option. If people say, you know what, I've been well for some time, I want to try it off medication. I don't have a long psychiatric history or a complicated psychiatric history. I really want to try to be pregnant and not be on medication. Okay, we'll support them. Maybe they need therapy during pregnancy. Maybe they need some extra follow-up visits just to be sure and to follow along and monitor. Then we can say, okay, let's watch and wait. Let's see how it feels. And if you develop symptoms during pregnancy, then we maybe start medication at that time. So a watch and wait approach during pregnancy. And third of all, some people say, you know what, and they do well. If in the third scenario, if people do well, they've come off medication, let's say they are doing well off medication in pregnancy, then again, we just watch and wait postpartum. And some people, even in that category, will say, I really struggled so much before. I want to start it as soon as my baby's born. I want to start medication basically right at delivery so it has time to get into my system and build up. And I just want that. Or again, if someone may say, you know what, I'm going to just watch and wait and see, and maybe have, we work on, okay, maybe you need to think about sleep. Maybe you need to get some extra parenting support around for dealing with child 1 when you're having child 2, or maybe you need some more supports around you in the postpartum period, or a night nurse so that you can sleep, or talk to your partner about splitting up the schedule so you can really sleep and they take care of the baby. So I would say there's a lot of moving parts and a lot of different variables to consider, but any one of those, stay on medication, watch and wait in pregnancy, watch and wait postpartum, are all options that people choose. The most important thing I'd say is to have support, to have therapy, to have people on the ball watching for symptoms, whether that's the patient themselves, their partner, other healthcare providers, and really paying close attention to how someone does along the way and along the journey.
Thank you. Well, if there's no more